Thank you everyone for joining us. This is the edition of Ask the Heart Doctor, where we're going to focus on valvular heart disease from diagnosis to treatment. My name is Amar Krishnaswamy. I'm the section head of interventional cardiology, and I specialize in the transcatheter treatment of valvular heart disease. I'm joined today by a fantastic panel of colleagues and friends. We have Dr. Xiao Lo, who is a cardiac surgeon and an expert in aortic valve surgery. We have Dr. Tarek Malas, who is also a cardiac surgeon and an expert in mitral valve surgery, and Dr. Serge Harb, who is one of our cardiac imagers and a specialist in the diagnosis and guidance of transcatheter heart procedures with cardiac imaging. We appreciate your engagement in this program. We've received almost 250 different questions. We're going to try to do our best to answer as many of them as we can in a comprehensive fashion. But please, if there are questions we don't answer, feel free to reach out, and there will be contact information at the end of this program. So Serge, I'm going to start out by asking you, we have a very interesting question here. Does valve disease always progress if it starts out mild? And if you can specifically address at every point the aorta, mitral valve, tricuspid valve.
Not always. So some valve disease, rather be it aortic valve, mitral valve, or tricuspid valve, can remain stable and mild. Others can progress, and it's mainly related to patient-related factors and other conditions, associated conditions that can predispose someone to progress. That's why follow-up is crucial to determine which patients are going to progress and to make sure that we're on track with the follow-up. And typically what we do for follow-up is frequent visits depending on the severity of the valve disease, which entails physical assessment, symptom assessment, and then usually echocardiography.
That's very helpful. And are there other tests in addition to echocardiography that may be helpful in trying to tease out whether the valvular disease is in the mild, moderate, or severe range?
This question comes up when there is a discrepancy between what the patient is reporting in terms of symptoms and what the echo is showing. Maybe sometimes the patient is very symptomatic and the echo doesn't show a significant valve disease. In these cases, we have additional testing that we can refer to, such as transesophageal echo, which is an echo through the mouth, and then which takes a closer look at the valves. We can also have tomographic imaging with cardiac CT or cardiac MRI, sometimes both, and also very importantly, as you know, hemodynamic assessments of valve, which you are an expert in, where we can see how much the valve condition is affecting the pressures in the heart and patient symptoms. And lastly, also exercise stress testing, which puts the patient on a treadmill and we try to exert them, because sometimes the valve disease may appear to be mild at rest, but when we exert the patient, we can see much more significant valvular disease.
So what I take from what you've said, which is I think a really important point for patients, is that sometimes the initial phases of testing might not show a severe valve problem, but if there are symptoms that are still concerning, that they should pursue further testing, perhaps sometimes even invasive testing, to better understand if the valve disease is in fact significant.
So true. And actually, we've seen a patient recently. I've seen a patient recently where the outside echo, where she had the testing, showed only moderate disease, and she was quite symptomatic. So she decided to come here for a second opinion. And when we did just the repeat initial echo, just because of how thorough our echocardiography is, we found out that actually she did have severe mitral valve disease. And actually, I'm going to refer her to Dr. Malas for intervention. So
that's very helpful. I think really instructive for patients. You mentioned a lot about symptoms. How do we know when a patient is ready to have treatment for their valve disease? Is it always based on symptoms, or are there other factors?
I think there are three main determinants to when the patient would need an intervention. First and foremost is symptoms, as you mentioned, meaning chest pain, shortness of breath, fatigue, dizziness, palpitations, sometimes, passing out, but also sometimes evidence of heart damage. So if you have a significant valve condition and then there is evidence of heart damage, then we sometimes refer patients for intervention, even if they are asymptomatic. And lastly, in some conditions, even if the patient is asymptomatic and even if there is not yet evidence of heart damage, we can refer them for intervention. I would take, for example, the condition of severe mitral valve prolapse with severe mitral regurgitation. We know that it's a structural problem. We know that it may not, it will not get better. And we know that our outcomes here, especially with surgeons like Dr. Malas, if we send them for mitral valve repair, we know that it's a very high success rate with very low complications. Similarly, with Dr. Lowe, if it's a patient who has severe aortic dilation, we're not, and there is, even though there is no impact, there are no symptoms, we worry about high-risk complications, and we know that operations such as these are very low risk with Dr. Lowe. So this would be a patient that I would refer for surgery early on before complications arise.
It's very, very helpful understanding for our patients that are listening. And as always, of course, it's a very patient-specific decision-making to understand the symptoms, the testing, and what may or may not be necessary. I'm going to move along now to Dr. Lowe. If we can address some of the questions we have around aortic valve surgery specifically, can you help us walk through what does a surgical aortic valve replacement really entail for the patient?
The incision to get access to that surgical valve replacement can vary. Here at the Cleveland Clinic, I think one benefit is that we have some variations to that approach. So if a patient is coming in for an isolated aortic valve replacement, we can offer a mini sternotomy, meaning that we don't go through the entire breastbone, but just a partial breastbone. So healing and all of those things and pain tends to be a little bit better for that patient. In addition, some surgeons also offer, a right thoracotomy approach into access that. So you don't necessarily have to end up with an entire, all the way down the breastbone incision. So we get access to the heart that way. And then in addition, then we put the patient on the heart-lung bypass machine, which takes over the function of the heart and lungs during the operation. And then we make a small, incision called an aortotomy at the side of the aorta. We open that up, we get access to the valve itself, so that valve is just looking in our faces, and then we can analyze what's going on with that valve. Generally patients are coming in for very severe aortic stenosis, so they have a lot of calcium or other deposits on that valve. So we carefully remove those leaflets. We clean everything up nicely. We take up every little piece of calcium, and literally we'll be picking at these pieces of calcium and make sure that all of those gets picked up appropriately, irrigate everything, and all of those pieces are really important to be removed out of the patient. And once everything is nice and clean on where that valve sits, we sew a valve back in, whether that's a mechanical valve or a tissue valve.
Very helpful. Thanks for that understanding. You mentioned mechanical valve versus biologic valves. How do you make a decision about one or the other, and are there differences in how long these valves last?
When a patient comes in with aortic stenosis, that valve does need to be replaced. And so the options are, in our prosthesis regimen, either mechanical valve, which just means that it's metal parts to that valve, and then a tissue valve, which can either be a cow valve or a pig valve. In the aortic valve position, we do a cow valve in general. And, the wear and tear of that valve is different for each of those prostheses. So we typically counsel that a mechanical valve is favored for a patient who's probably under the age of 55 or so, 50, 55. The benefit of that mechanical valve is that theoretically it should last your whole life. But the drawback is that a patient has to be on a blood thinner called Coumadin their whole lives. And so that's a medicine that has to be taken every single day. And your blood has to be a certain level of thinness. Now, we have better mechanical valves now, so your blood doesn't have to be quite as thin as it used to be, but it is still, a mechanical valve that needs to have have things that are carefully monitored in your bloodstream. In addition, the alternative is a tissue valve, which is a cow valve in that position. We do know that once that cow valve goes in, there is kind of a clock on that valve, and that there is an expected wear and tear on that valve. And generally, the data says about 15 to 20 years or so, that valve needs something else done at that point.
Very helpful. Now, there are some patients, particularly those who have a bicuspid aortic valve, and whether that valve degenerates with aortic stenosis or aortic regurgitation, they may also have associated pathology of the aorta above the valve or aneurysm. How do you assess those patients, and do you do a surgery on the aneurysm and the valve at the same time?
Yes, great question. So I think that's the benefit of coming into a comprehensive center, is that we have some options for patients who come in with aortic valve leakiness or insufficiency. So, for instance, for the bicuspid patients who come in and they're often associated with aortopathy or aneurysms of the aorta, either at the level of the root or the ascending aorta or beyond, there are some options for patients who are younger, and perhaps that valve could be repaired rather than fully replaced. And so I think at the valve level for a bicuspid valve, if it's not stenotic or calcified, we compared to some other centers, we really try to repair those valves in young patients. And there are various repair techniques, and we've, as a center, have published extensively on those repair techniques, and have found that they are as durable as, patients who come in with a 3-leaflet valve that end up getting repaired as well over time. So that's, a really good option for younger patients, because the alternative would have been a mechanical valve. And then in addition, if that bicuspid valve is, reasonable, working okay, but they have a root aneurysm, we offer valve-sparing root replacements where we are able to keep the patient's valve, maybe do a little bit of plastic surgery, tightening up here and there to prevent them from being, severely insufficient, and then just replace the area around the root. And then also offer an ascending replacement, whatever you need at the same time. And our threshold for going in for that aneurysm is a little bit smaller if we're going in after the valve itself as well. Typically, we do an aneurysm replacement when the aneurysm is at 5 centimeters. For a valve, if we're doing the valve at the same time, we lower that to about 4.5 centimeters. So we really try to offer a comprehensive approach for the patient at the first time of their surgery to try to prevent them from needing, multiple heart surgeries down the road. One is enough.
So I think to summarize, we have a lot of different ways that we can access the chest for patients who require aortic valve surgery. I think most often in patients with an isolated aortic valve problem, you're approaching with a minimally invasive incision, which is a somewhat unique approach that U.S. surgeons have here at the Cleveland Clinic. And in those patients who require an aortic valve surgery and an aneurysm surgery, those also can often be approached by a minimally invasive incision, as I understand.
Yes.
And then the choice between a biologic valve and a mechanical valve is really, again, a patient-specific one.
Yes.
Takes into consideration factors like age, ability to tolerate blood thinners, and so forth.
Right, absolutely.
There are a number of questions here about transcatheter aortic valve replacement, so I'll try briefly to summarize. So transcatheter aortic valve replacement, or TAVR, is a procedure where most commonly we place a small catheter or a tube in the artery at the top of the thigh, whether the right leg or the left leg. And through that tube, we pass a catheter that has a valve on the end of it. There are a few different types of valves and sizes of valves that we can use. Again, these are all very patient-specific and based on an analysis of their imaging. The procedure is generally performed under what we call a conscious sedation or a monitored anesthesia care, where there is an anesthesia team there to keep the patient comfortable, but they're not under a full anesthesia or a breathing tube or anything like that. We place the valve from the leg into the aortic position, and we expand the valve into place, pushing aside the native aortic valve and leaving in place this new prosthetic. We don't actually take out the native aortic valve, but it just gets pushed aside. The prosthetic is always a biologic prosthetic or a bioprosthetic valve, so it doesn't necessarily require anticoagulation. Usually we just continue the patients on a baby aspirin. For the most part, the procedure takes about 45 minutes, and at least at Cleveland Clinic, about half of our patients go home on the same day as their procedure. There's a question here about if you have had a prior aortic valve replacement, can you have a TAVR? If the aortic valve replacement was a bioprosthetic valve, we can do a TAVR routinely as we would in a native aortic valve. We simply place that TAVR inside of the surgical valve and expand it into place. If the surgical valve is a mechanical valve, that is not something that can be replaced at the current time with a transcatheter strategy. Another question here, can you have TAVR if you're at a low risk for surgery? So for the most part in the current era, on the basis of trials that have compared TAVR to surgical valve replacement at all levels of risk along the surgical spectrum, low, medium, high, and prohibitive, we've demonstrated that TAVR and surgical valve replacement are generally equivalent strategies with regard to both durability of the valve prosthetic as well as the safety of the procedures. Now, certainly in patients who are considered at a high risk for surgery or a prohibitive risk for surgery, a TAVR will be a safer option, and that's the preferred strategy. In patients who are at a low or even an intermediate risk for surgery, at Cleveland Clinic, our results are relatively similar with regard to the safety of either of these procedures. And the decision for what's the best option or a best pathway of treatment for a patient is based on very specific anatomic considerations. And especially in the patient who is younger or at a low risk for surgery, we want to look at not only how safe is a TAVR procedure or how safe is a surgical procedure, but also what can we do in the future. As Dr. Lowe recommended or mentioned, the surgical valve or the TAVR valve, when they're bioprosthetic, are going to have a lifespan of anywhere between 10 and 15 years. And when that valve fails, we want to know that we can place another valve inside of it with a TAVR, because it would make more sense for a patient who's, let's say, around 70 years old to have a more invasive procedure if necessary when they're younger rather than when they're older. So if that young or low-risk surgery patient can have a TAVR both now and a TAVR inside of that TAVR 10 years or 15 years down the road, then that's a very suitable patient to have a TAVR when they're low risk or younger. I have a question here about what can you do if you have a TAVR that has failed. There are a number of different ways in which surgical valves or transcatheter valves can fail. I'll speak from the transcatheter perspective, and Dr. Lowe, if you can mention from the surgical perspective. So if there's a TAVR that has failed, it can either be because the leaflets or the mobile parts of the valve itself are no longer working properly, either causing bioprosthetic valve stenosis or regurgitation. In those situations, often we can place another TAVR inside, but again, that's an analysis we have to make based on CT scans and other imaging tests. Again, we're going to consider what is the age of the patient and is the best thing for them to have another TAV in TAV, as we call it, at the current time, or are they better suited to having that TAVR taken out, having a surgical valve replacement, and then considering a valve-in-valve TAVR in the future. There are also scenarios where the TAVR can be leaking outside of the valve frame, and those require different treatment strategies, which are often, again, transcatheter or percutaneously addressed. Dr. Lowe, I'd like to turn to you. How would you deal with a surgical valve or a transcatheter valve that's failing? What are your thoughts?
We experience that a lot here because we get patients who have had these complicated cases done at some other, other centers or even here, wherever, and they failed over time or they get infected. That's another reason for those valves failing as well. And so we get a lot of these patients who come in and they've had prior surgeries or prior TAVRs. So it really is a heart team discussion also. I think that's a big part of this, and it's very much dependent on the individual patient. We really look at the patient, their risk factors, what is their tolerance for getting open heart surgery, their age, all of those comorbidities that factor in. And we try to make a decision from a heart team approach about what will be the best to offer, durability and something that's safe for that individual patient. I would say, someone who's probably in their late 80s who comes in and they've had a prior prosthetic valve that is failing now and it's not infected, then, TAVRs are a really good option for those patients. And otherwise, if it's a younger patient or the valve is infected, TAVR doesn't take care of the infection. If there is an infected valve that's the cause of the failure, we do have to, I think, move towards the open heart surgery approach to take out that valve and accept kind of the risks of that operation and just do our very best for that patient to get them through. But the TAVR would not address the infection. And we do see that a lot, unfortunately, with very tough cases.
Absolutely. Very helpful. And finally, to close out, I think I mentioned just briefly, how long do TAVRs last? For the most part, based on the benchtop testing that was necessary for these valves to be approved, as well as the clinical experience that we've had over time, there's a relative similarity between the durability of a surgical aortic valve replacement and that of a transcatheter aortic valve replacement. Generally, we're looking at approximately a 10 to 15 year durability, again, with options for treatment when the valves fail, as we've discussed. Turning to you again, Dr. Tariq Malas. He's one of our cardiac surgeons and a specialist in surgery on the mitral valve. A number of questions on mitral valve surgery here. Dr. Harb has mentioned to us when we make the decision for someone to need a mitral valve surgery. So now they've come to you. What are how do you parse out, does someone require a surgical mitral valve repair or a valve replacement?
We get a range of patients that have different pathologies, and I rely on experts like Dr. Harb to give us information about the valve and try to understand the valve better. Generally speaking, a valve can either leak or it can be stenotic, meaning it's calcified and it's not moving very well. When the valve is calcified and it's stenotic, we usually lean on a mitral valve replacement. We prefer to replace those valves because repairs don't generally last very long in that type of group. Versus a valve that's leaking, in the majority of cases here at the Cleveland Clinic, we're able to repair those valves. And that really depends on the type of pathology. And that's where we require certain imaging to understand the valve and an expert by our heart team to make that decision. And the best judgment to repair the valve is also made intraoperatively when we take a look at the valve with our eyes and we make the decision whether we can repair or need to replace that valve.
That's really helpful, Tariq. Thank you. I always find it striking that there appears to be very clear data that for patients who have degenerative mitral valve regurgitation, so mitral valve prolapse or flail, that unquestionably the outcomes are better for someone who's had a valve repaired than someone who has had a valve replaced. And this is both functional outcomes and survival outcomes. And yet, nationally, many surgeons don't end up repairing the valve. And the last statistics I saw were that for somebody with a degenerative mitral valve, less than half of the patients are actually having a valve repair as opposed to a valve replacement. So at Cleveland Clinic, for you and the mitral valve group, what percentage of patients with a degenerative mitral valve are having a repair?
Unfortunately, we do see that variation in data. There are studies that show that centers that have a higher volume of mitral valve repair tend to do much more repair and do a better job at that. And this is why centers of excellence are the best place to have that type of repair. At the Cleveland Clinic, we repair a majority. If we look at, for example, our robotic background, Mark Gillenov and myself do robotic mitral valve repairs, we have a 99% repair rate, and the mortality rate is extremely low, less than 0.05%. And that speaks to the experience and the expertise in that field versus looking at other centers that do not repair these valves and replace these valves. Unfortunately, in the long term, replacements, while are fantastic surgeries, do have a smaller survival compared to repairs. And this is a tenet that we hold very dearly here at the Cleveland Clinic, is we try to repair valves if we think they're repairable.
That's very helpful. You know, Tariq, you mentioned there briefly something about robotic mitral valve surgery. It sounds futuristic and very exciting. Can you help us understand a little bit what is robotic mitral valve surgery and how do you decide, can all patients have a robotic mitral valve surgery?
Robotic surgery is an excellent alternative to open heart surgery. It's not for everybody, but we have certain criteria that we look at. First of all, we look at patient factors, we look at anatomical factors, and finally, we look at the valve. We make sure that the valve is a good valve to repair or replace. Currently, we can do both replacements and repairs with a robot. We do have to have preoperative testing, and we rely on experts like Dr. Harb as well to look at the valve, to understand the pathology, and also we look at important anatomical factors like how calcified is this valve repairable? And then that gives us a decision as to see if somebody is a robot candidate or not. And we usually perform the robot surgery without having to cut any bone. So rather than go through the sternotomy, which is the incision that we cut the breastbone, we actually go through the side between the ribs. And that involves a small incision of about 4 to 5 centimeters. And we insert 3 robot arms between the rib spaces, and that truly almost like a video game console. You sit in a console and you control the robot arms to do the repair. And our results have been excellent in that. The beauty about robotic repair is you're able to see the valve about a 10-time magnification, and that allows us to assess the valve better and to perform a durable and strong repair. Again, we usually go through the heart-lung machine, through the legs, so we use anatomical criteria to make that decision. So if you're to come here for robotic surgery, you'd want to have a CT scan to look at the anatomy and make a decision as to whether you're a robotic candidate or not.
That's really exciting. And parenthetically, Tariq and I were just talking the other day, and he told me that even if he has an extra strong cup of coffee and his hands get a little shaky, the robot can actually steady the hands. We have a lot of questions here about less invasive or transcatheter treatments for mitral valve disease. these questions came through as asking about the MitraClip. What I would mention is that the MitraClip was sort of the historic and sort of predicate device, the first device approved. We now call the procedure transcatheter edge-to-edge repair, or TEER. So all of my answers are going to specifically use that term to those of you who know it as MitraClip, but there is another device that's approved called the Pascal device, which is a somewhat similar, somewhat different device, but affects a similar transcatheter-based treatment of the mitral valve. What we do for the TEER procedure, again, this is for patients with mitral valve regurgitation, whether it's primary or degenerative mitral valve regurgitation or secondary mitral regurgitation that we used to call functional. We place a catheter at the top of usually the right leg in the right femoral vein, and we pass that catheter up to the mitral valve. And on the end of that catheter is this TEER device that looks like a little clothespin, and if the valve isn't coming together properly, we can actually hold the valve together. As opposed to TAVR, this is a procedure that is routinely done under general anesthesia with a breathing tube, not under conscious sedation. And for the most part, the procedure can take anywhere from 25 minutes to 2 hours. It really depends on the complexity of the mitral valve disease, whether we have to place one device or more than one device, and various different analyses that we do during the procedure to make sure that we're affecting the best solution, the best treatment option for that patient. There's a question here: how effective is the MitraClip for mitral valve regurgitation? For the most part, both the technology of TEER as well as the imaging and the guidance provided by Dr. Harb and his colleagues have improved substantially over the last 15 years that we've been using the TEER devices. As a result, and for the most part, we find that more than 90% of patients will be left with less than a moderate degree of mitral valve regurgitation, and that's what we consider as the standard for a good result. Generally speaking, over 91% of patients in recent series will have one plus or less mitral valve regurgitation at the end of the procedure. I will make the caveat that we do treat a number of patients with a TEER device who are not, in fact, anatomically good candidates for a TEER procedure, but either due to age or different comorbid conditions, they're simply not candidates either for a transcatheter-based mitral valve replacement or a surgical mitral valve repair or replacement. And we know that for those patients, when we analyze them in a case-by-case basis, that even if we cannot affect an A+ strategy for a TEER procedure, even reducing their mitral valve regurgitation to some degree can be beneficial with regard to functional outcomes and how they feel in their day-to-day. So I think this is an important consideration. It's not always just about how low is the final mitral regurgitation grade, but are we doing it for a patient that doesn't have another option and we can still help them to feel better. There's a question here: for someone over age 75, is a TEER procedure a better option? So as with everything, including with aortic valve disease, mitral valve disease, our decision making here is not based simply on age, but looking at the valve pathology, how effective can we be with a TEER procedure versus with a cardiac surgery, what are the other conditions that the patient is facing. And so we tend to focus a little bit less on age than we do these other factors. It's true that for the most part, for somebody over the age of 80, their surgical risk is likely going to be higher. And at the current time, we focus on TEER device treatments for patients who are considered at a high risk for cardiac surgery, and this is based on the FDA approvals. Having said that, those approvals are over a decade old. And we know, again, as I mentioned earlier, that the technology of the TEER devices and the imaging that we use to direct these procedures is far better than it ever was. And so our head of cardiac surgery, Dr. Mark Gilanov, along with a cardiac surgeon named Joe Chikwe at Cedars-Sinai, are leading an NIH-sponsored trial called Primary, where we take patients who are above the age of 60 at any level of surgical risk, who have suitable anatomy for a TEER procedure or a mitral valve surgical repair, and they're randomized between one or the other. Again, this is not a decision made in isolation. We all analyze these patients as interventional cardiologists, cardiac imagers, cardiac surgeons to say that we all feel that these can be an equivalent strategy, surgery or transcatheter treatment for these patients, and that's how the patients get randomized. If there's a younger patient who is at a low or even an intermediate, medium surgical risk, who's not interested in the randomized trial, then the only option at the current time is for a surgical valve repair, as Dr. Mallas has elucidated for us. A question here: if you've had a mitral valve repair in the past, can it be repaired again or does it need to be replaced? Perhaps I'll address that from a transcatheter perspective. Dr. Mallas, if you can answer from a surgical perspective. Whether someone has had a transcatheter TAVR procedure in the past or a surgical mitral valve repair, there are opportunities for us to repair that valve again with a TAVR device in either of those situations. The key decision making there is based on the anatomy, and that anatomy is information we get from imagers like Dr. Harb to show us exactly what's wrong with the valve now, why is it leaking again, and can we fix it with a TAVR device. If you've had a mitral valve replacement in the past, universally those patients tend to be a bit more elderly, often at a higher surgical risk, and it is very rare that we cannot do a transcatheter valve replacement for someone who has a failing surgical mitral valve bioprosthetic. Dr. Mallas, let me turn it to you. What do you do for a patient who has a recurrent mitral valve regurgitation or a stenosis after a prior surgical valve repair or even a TAVR?
This speaks highly of the way we function here at the Cleveland Clinic when we have experts like Dr. Krishnaswamy and Dr. Harb, and we sit down together as a group and we look at each patient on a case based on the patient's values. We look at the patient's imaging, and we also look at factors like age and comorbidities, and that helps us get a global idea of what the best treatment strategy is. And this is something we discuss together before offering either a surgical intervention or a transcatheter repair. In my practice, we have been able to re-repair valves in a good majority of patients that come back with mitral valve regurgitation after a previous failed mitral valve repair. And that decision is difficult to make. I mean, we look at the imaging, of course, initially, but the best time to make that decision obviously is in the operating room when we evaluate the leaflet quality, what type of pathology is causing the issue. If it's a stenotic valve, then we replace that valve. Sometimes you can repair that valve as well, but in the majority of cases we replace. But if it's a valve that has leaked again after a previous repair, then we can either repair or replace that valve. I would say in about 50% of cases, to give an approximation. And if we can't repair the valve, then we replace the valve, and that sets us up perfectly for the future for a transcatheter approach as well. If we have a failed MitraClip, then we can replace that valve in the majority of cases, and that really depends on the the procedure that was done, the age, the comorbidities, and that's something that we studied together as a group.
Very helpful. Thank you. I'm going to turn our attention now toward tricuspid valve pathology and tricuspid valve regurgitation. For a long time, this was a valve that perhaps people would have treated if they were having another cardiac surgery, and then you guys would go ahead and repair the tricuspid valve itself. But in more recent times, we've become more attuned to people who have symptoms result of isolated tricuspid valve regurgitation, or perhaps the long-term ramifications of tricuspid valve regurgitation on the heart and the quality of life. So perhaps, Serge, I can turn it back to you. In patients with tricuspid valve regurgitation without other valvular heart disease, perhaps they've had valve surgery in the past that's functioning well, how do you analyze the tricuspid valve? Again, getting back to one of our early questions, if someone has a mild or a moderate degree of tricuspid valve regurgitation, do those patients need to be followed? And then finally, how do you make a decision to say, should that patient be referred for a transcatheter or a surgical treatment of their tricuspid valve?
As you mentioned, tricuspid valve used to be the forgotten valve, and now there is so much attention on the tricuspid valve. In terms of evaluation, the most important test to start with is an echocardiogram, just to understand the amount of leakage, and the consequence of such leakage, meaning is it causing right-sided enlargement, and is it a resultant of high pressures within the heart. Once we've made a determination about the severity of the leak, then the follow-up and the management depends basically on how bad it is. So typically for mild conditions, we tend to follow them up with probably every 3 to 5 years, depending most importantly on patient symptoms. For moderate lesions, it's more frequent, maybe every 1 to 2 years. And then for severe lesions, then we are really considering if there is a need for intervention. And the decision to intervene, as discussed before, is mainly based on 3 criteria. One, patient symptoms. And what are symptoms of tricuspid leak? Mainly, fatigue, leg swelling, abdominal distension, hepatic congestion, and being short of breath. So if there are no symptoms, then what we're looking at is there any signs of heart damage? And meaning by heart damage in the tricuspid side, is there a significant right ventricular enlargement? Is there significant right-sided dysfunction? And then lastly, in some cases, when there is a severe leak, we may consider intervention if the patient is asymptomatic. But these are like very much case by case, and a multidisciplinary team approach, as Dr. Malas and Dr. Lowe have been mentioning, where we sit all together, minimally invasive interventionists such as Dr. Kriswami or surgeons, and then we make the decision to intervene. Once we've made the decision to intervene, then the question is it surgery the best route, or is it transcatheter minimally invasive options which is the best route? And again, it's a team approach. We have every patient, once they're done with their testing, meet a surgeon and meet a team member in the structural team, and then we have a discussion and then weigh the pros and cons, taking into consideration patients' preferences, patients' expectations, and then make a decision about what therapy is best, especially now that the FDA has recently approved 2 transcatheter options, one for repair, which is edge-to-edge repair, as Dr. Swami has mentioned, and then replacement. And the decision to repair, replacement, minimally invasive, or surgery is a multidisciplinary team approach.
Thank you, Serge. Before we get into the details of either a transcatheter treatment strategy or a surgical treatment strategy for tricuspid valve regurgitation, can you just touch on some of the associated conditions with tricuspid regurgitation, and how do we involve our electrophysiology colleagues with regard to heart rhythm management strategies? Also, how do we involve our heart failure colleagues with regard to the medical therapies that are there?
Most tricuspid leak are resultant of associated cardiac conditions, meaning a small percentage are related to just the valve having a problem in itself, as opposed to the mitral valve where we spoke about prolapse, flail. It's quite uncommon on the tricuspid valve, and most tricuspid leaks are related to associated cardiac conditions such as, heart failure, pulmonary hypertension, other valve disease on the left side, and then very importantly, what Dr. Swami mentioned is involvement of the electrophysiologist, and the reason why it's not uncommon for a pacemaker lead that's crossing the tricuspid valve or a defibrillator lead that's crossing the tricuspid valve to be in somewhat a culprit in the initiation or even in the progression of tricuspid leak. So once you start dealing with a lead that's interfering or causing the leak, or even interfering with the therapy that can be offered, meaning if the lead is in a place which makes it challenging to repair it via minimally invasive route, then we involve our electrophysiologist to try and discuss plans about how to manage the lead. Should we remove it? Should we replace it with a leadless pacemaker, meaning a pacemaker that doesn't cross the tricuspid valve, just sits in the right-sided chambers, or even a surgical option of leads outside, not through the tricuspid valve, or maybe a defibrillator underneath the skin. And also involvement of our heart failure colleagues for multiple reasons, mainly to help us manage the right-sided failure with mainly diuretics and other treatment, but also because sometimes tricuspid leak is a manifestation of a global heart disease, and then a heart failure where the left side is weak and it's causing the back filling of, and increased pressure in the heart, leading to tricuspid leak. So it's truly a multidisciplinary approach. It's a very complex, valve condition to have. We have treatment options. It just involves multiple people from multiple specialties all sitting on the same table and trying to figure out what would be the best option for this specific patient.
It's really helpful. Great insights, Serge, into sort of the patient journey and the number of different people that they'll see if they're coming for treatment for tricuspid valve regurgitation, to make sure that we're sort of hitting all of the points of how they need to be treated. Number of questions here about surgery and transcatheter treatments for the tricuspid valve. I'll start on the transcatheter side. As Serge mentioned, earlier this year, we had a couple of treatments, transcatheter treatments for the tricuspid valve that were approved by the FDA. One is the EVOQUE transcatheter tricuspid valve replacement, and the other is the TriClip, which is a TEER device, just like on the mitral side, instead on the tricuspid side. There are a number of questions here about how these procedures are done, how the results compare. So I'm just going to try to address this from a 30,000-foot view. Both of these procedures, transcatheter tricuspid valve replacement or transcatheter tricuspid valve clipping or TEER, are done under general anesthesia with a breathing tube in. We place the device at the femoral vein at the top of the right thigh or the left thigh, and through that tube, we take the device up to the tricuspid valve. For the valve replacement, we push aside the native tricuspid valve, leaving the EVOQUE valve in place. For the tricuspid valve clipping or TEER, we simply bring together the edges of the tricuspid valve, similar to what we would do on the mitral side for TEER. There have been no comparisons of the transcatheter tricuspid valve replacement with the TEER strategy or repair strategy. So really, these decisions are made based on patient-specific anatomies. For those patients who have a suitable anatomy for clipping, that's often the way in which we will proceed. For those patients who are unsuitable for clipping, usually we'll use the replacement strategy. Patients often ask if they have a lead in place. So as Dr. Harb mentioned, sometimes the lead can interfere with the tricuspid valve function and cause leakage. We often can still do clipping for those patients. If clipping is not suitable based on that anatomy and there's a lead through the tricuspid valve and we plan to do a tricuspid valve replacement, we'll often have our electrophysiology colleagues involved to decide, do they need to remove that lead, not because it's going to make the regurgitation better, but because we don't want to trap that lead behind the prosthetic valve that we're going to place. The reason for that concern is that all leads have a certain risk of infection on an annual basis. And if a lead gets infected and it's trapped behind a transcatheter valve, it can be very complicated or nearly impossible to then extract that infected lead. So again, it's a very important thing to have a conversation between the implanting team and the electrophysiology team to really decide for a given patient what's the right strategy for that lead management. These transcatheter treatment strategies have become much more popular in recent years and with a lot more study, primarily because surgery was historically considered a very high risk for this group of patients with isolated tricuspid valve regurgitation, with concerns about both the surgical treatment and the recovery from surgery. And so that's really where the transcatheter treatments came about. But what we have found, as we've seen more and more patients with tricuspid valve disease, and oftentimes who have not been good candidates for a transcatheter treatment strategy, that our surgeons have taken them for what were, again, historically considered high-risk surgeries, but really with very effective treatment and good outcomes. So I'll turn it over to Dr. Lowe and Dr. Malus. How do you guys approach tricuspid valve disease surgically in the current time?
What we're all getting at is it's actually the tricuspid valve, an isolated tricuspid valve lesion where only that valve is affected and none of the other valves are affected, is not that common. It's not as common as the other valves being affected. And so for isolated tricuspid valve disease, it very much, as everyone has mentioned, it's a heart team approach to figure out what the best thing to do for that patient is, and also to assess, how leaky that valve truly is, if it is, in fact, that we're going after this for tricuspid tricuspid insufficiency, because it is a valve that's very dependent on the patient's status overall, their heart function status, and their volume status. So we see it a lot in patients who have, overall a lot of volume on board, and then that valve is really quite leaky when they're super fluid volume up inside their bodies, and when they've diuresed it, or sometimes in kidney patients when they haven't had the dialysis session in a few days, they get that off and that valve magically looks a little bit better on the echo study, and it's no longer severely leaky, it's only mildly leaky. So it is sometimes very dependent on all of those things. So I think we do all of these testing, and sometimes we need to do invasive testing, as Dr. Arb was saying, with right heart catheterizations to look at whether there's truly an indication to go after this valve. Because from a surgical perspective, there are things we can do to repair this valve. Typically, when we see it in the setting of if we're going after left-sided disease, because everything from the left side is leaking backwards to the right side, and the right side has been problematic or it's an ischemic issue, putting just a ring around that tricuspid valve and tightening the waist of that valve a little bit will solve the problem, and that valve becomes no longer leaky afterwards. It is a valve that I think less is more. It helps for that particular valve, and patients can tolerate some degree of leakiness. It doesn't have to be, as you were saying, an A+ situation on that valve. Even some mild leakiness on that valve, patients generally tolerate that very well for their whole lives. The other option, we don't like to do this, and I think it's very rare that we end up doing this, is to replace that valve. And the reason being that it's on the right side of the heart, which is just a slower flowing blood flow across that side of the heart. And so there's just a greater risk of things clotting around that valve, even when it's a tissue valve. And the conduction territory is right there. So anytime we put in any kind of valve where we have to put stitches around, part of where that valve sits is where all the conduction inside the heart is going on. It really can affect the conduction system. And then, we're looking at not just the valve getting put in, but also putting in a pacemaker for that patient. So it's definitely a tricky, I think, valve. And we are, as I think, surgical society are also trying to figure out better ways to treat this valve. Better repair techniques besides, and very, very, very few often, that we're actually replacing this particular valve.
Sometimes you can replace certain parts of the valve with what we call autologous tissue from our own body, and sometimes we can place cords to try to repair that valve. But in the majority of cases, sometimes just protecting the waist with a band is sufficient to get the outcome, especially if the valve is dilated with time, and bringing that together can solve and bring the leaflets back together. Just to echo Dr. Lowe's comments as well, generally speaking, it's pretty rare that we do an isolated tricuspid valve replacement, and having transcatheter options has been fantastic, and we rely on our colleagues like Dr. Krishnaswamy to provide guidance as well on that.
Thank you, guys. So just as we close out, a couple of final questions here. So Serge, someone has had their valve repaired or their valve replaced, whether it's by a transcatheter means or a surgical means. How often should that patient be seeing their caregiver, both for clinical assessment and for an imaging evaluation of that result?
It really depends on the success of the repair or replacement, and also patient symptoms. But typically, generally speaking, we tend to at least follow them yearly. If there are problems, if they have symptoms, or if the valve repair was not that successful, the valve replacement is starting to show some valve dysfunction, then of course it's going to be more frequent. So it's typically guided by patient symptoms and the initial repair and the findings on the follow-up echocardiograms. As you said, it's mainly a follow-up with physical exam, symptom assessment, and also echocardiography.
People often ask, how long do they need to take antibiotics after a valve repair or a valve replacement if they're having dental work or some other surgical procedure? What's the general recommendation?
The general recommendation, if you had prior surgical intervention with surgical material or transcatheter material inside the heart, we recommend antibiotic prophylaxis before invasive dental procedures. For general dental cleaning, the risk is quite low, but for more invasive stuff such as tooth extraction, an abscess, manipulation of the gingival tissue, or like perforation of the oral mucosa, anything that's invasive, we recommend antibiotic prophylaxis. And typically, amoxicillin, like 2 grams, just half an hour to an hour prior to the procedure. So this is the typical recommendations to prevent endocarditis, which is an infection of the surgical material or the transcatheter material that's inside the heart. We also are very vigilant in patients who have prior infective endocarditis to recommend the prophylaxis, and in patients who have some conditions of congenital heart disease.
Very helpful. Well, thanks again to Dr. Harb from cardiac imaging, Dr. Malas from cardiac surgery, Dr. Lowe from cardiac surgery, and to those of you watching, appreciate your time. Take care.